Let me begin by saying we were founded in 2018, and I want to give credit where credit is due. The lab of Dr. Erwin Van Meer, who's now at University of Alabama, Birmingham. He did most of this work at Emory, and he's one of the biology co-founders. And then Bing Wang is a chemist at Georgia State who created one of the compounds I'll be telling you about. So we're focused on with advanced and aggressive cancer. Our approach is to develop a proprietary dual HIF1 and HIF2 inhibitor as part of combination therapy for advanced cancers. And the combinations are guided by preclinical studies that demonstrate therapeutic synergy. We have a broad collection of in-licensed compounds, initially focused on a compound called 64B. And we have preclinical proof of concept on combining with anti-tumor agents that work in well-oxygenated areas of advanced cancer. So HIFs are an attractive target because they're activated in most cancers and contribute to tumor survival and spread. So basically what happens is that tumors grow. This is a malignant brain tumor. It's a xenograft. These are blood vessels, and the brown is using a stain called pimodinazole that identifies hypoxic areas. Toxic areas are not dead, and in fact, they're biologically very active through the expression of HIFs, and there are two different HIFs, HIF1 and HIF2, that end up driving expression of genes that help the tumor cells survive and spread to new regions. And you don't have to get very far from a blood vessel before the hypoxia occurs. Now, I've often been asked, how common is hypoxia in tumors? And so this was from a review article that looked at the oxygen tension in tumors shown in green versus their normal tissue in blue, and showing that the vast majority of tumors have regions of measured was not exclusively looking at the hypoxic areas, but showing that in general, there was a lot of hypoxia. Now, HIFs are a complex family process, and there's HIF1 alpha and HIF2 alpha, the alphas being the oxygen sensitive subunits. In the presence of oxygen, the alpha subunits get Lindau protein, which then leads to ubiquitination and targets the alpha subunits for degradation by the proteasome. In the absence of oxygen, or in hypoxic conditions, that hydroxylation does not occur, and hence there's no binding of the VHL or targeted degradation. And instead, then CBP P300 can bind to the alpha subunit. The HIF1 beta subunit combines, leads to formation of the complex, and the transcription factor is stabilized, leading to transcription. Now, our goal was to block activation of the HIFs because the genes that they drive expression of regulate expression of many different processes that aid in tumor survival and spread. And there are broadly two different HIFs, HIF1 and HIF2, consisting of an alpha and beta subunit. And they regulate the expression, the induction of some shared genes like VEGF and PDGF, and then some distinct genes like OCT9 and LDH, genes involved in regulation of processes that including cell migration and invasion, ability to switch energy sources, things that affect, so they can overlap. Now, I'm by agents that where over 10,000 compounds were screened, and then from that screen there was further structure activity optimization. And I won't go through this other than to say we selected a compound for initial characterization that is called KCN1, and it's based on both some of its stability and pharmacologic properties. And so initial efficacy studies were done with a glioblastoma model in mice. Now, this is a subcutaneous model where tumors were established, and then looking at the ability of KCN1 versus vehicle to inhibit tumor growth. And so the red shows the treated and the control, and these are the actual tumors. And it's some tumors completely didn't develop or were disappeared, and then others were just dramatically smaller. At the termination of the experiment, the tumor mass was measured and growth rate also determined. And so the bottom line is that KCN showed a lot of efficacy, but it doesn't cross the blood-brain barrier effectively. So, so there were some additional SAR studies done, and we created a more potent compound that has same mechanism of action that crosses the blood-brain barrier, and that is called 64B. And just showing the relationship between KCN1 and 64B, this group has been substituted for this, and then there's an N here. And importantly, there's it crosses the blood-brain barrier and is more potent. So we've looked at a number of different types of cancer for efficacy, including breast cancer, lung, and glioma, using either 64B shown in blue, which are the more recent studies, or the original studies that were done with KCN1 shown in black. And the bottom line is for all of these tumors, so the bottom line is that as a single agent, these agents were having an effect on primary tumor growth of many different types of cancer. They also had an effect on metastasis, and this is shown in a orthotopically implanted lung cancer xenograph in mice looking at the contralateral lung. And this is a metastasis in the control, and this is showing a lack of metastasis in the treated. And the lungs were sectioned and numbers of nodules counted and plotted here for the different mice. And so highly statistically significant in 10 mice. Now, how does it work? Well, it turns out that 64B and KCN1, we've done it with both, inhibits the recruitment of the transcriptional cofactors P300 CBP to the HIF transcriptional complex. So this is a Western blot in normoxic and hypoxic conditions in the absence and presence of 64B, and showing that hypoxia induces the stabilization of HIF-1 alpha, and that 64B doesn't block that. But instead, what happens is that when you try and immunoprecipitate HIF-1 alpha, then in the presence of 64B, and then stain for CBP, then there's no longer an association. So that disappears. And in doing some thermal shift assays, in looking for the binding between 64B and P300, where the thermal stability, the interaction leads to a higher melting temperature, then one ends up seeing additional data on the interaction between the two. And the control was a variation on 64B. This blocks HIF function. This derivative does not. And so similarly, it doesn't bind. So back in 2002, Friedman et al. Published information on the crystal structure of CBP P300, which are related, very structurally similar proteins that bind HIF1, and identified the HIF1 binding site as the CH1 domain. And this is far removed from the histone acetyltransferase activity or sites that are involved in binding many other transcription factors. It's easier to see linearly, but when you end up, these are the structures when they're folded. So lo and behold, where 64B and KCN bind is to the CH1 region. And in fact, with some molecular modeling, the purple, this shows the molecules and the interaction on the CH1 site of CBP P300. So other groups have attempted to inhibit the HIFs because it's an attractive target. And there was an antisense to HIF1 alpha that went through clinical trial that failed in phase 2 clinical trial. And my suspicion is it's for two reasons. Number one, it didn't fully block HIF expression or the downstream targets. And also it had no effect on HIF2 alpha. And we now know that many cells, tumor cells, will express both HIF1 and 2 alphas in response to hypoxia. Now there's currently a HIF2 specific agent that is in phase 3 clinical trial for renal cell carcinoma called PT2977. And what that does is it blocks the dimerization of HIF2 alpha with HIF1 beta, but it has no effect on HIF1 alpha's dimerization. So it's a HIF2 specific agent. And what our compounds do are they block the specific interaction between CBP, P300, and both the alpha, 1 alpha and 2 alpha subunits. And so it disables the function of both HIF1 and HIF2. And this should be of therapeutic advantage because of the role of both. Now, cancer cells have both normoxic and hypoxic regions, so both need to be targeted. And this is illustrated by, here you have a blood supply and tumors outgrowing the blood supply, becoming hypoxic, but these tumor cells also need to be treated, and they're well oxygenated. And so the question is, can 64B be safely given with agents that work in this region and complement the inhibition of survival and spread genes that are induced in this region? And the answer is yes. So this is using a lung cancer xenograft model, A549 cells in nude mice. and comparing the vehicle control to 64B, our HIF inhibitor, to docetaxel, which is an FDA-approved agent for lung cancer, or the combination of both. And what this shows is that both 64B and docetaxel are comparably effective at decreasing primary tumor growth. And when you put the two together, you see synergy. Now, this is looking over time with the treatment and then tumors harvested at the completion of the experiment, weighed and plotted over here. And you can see the composite of the individual tumors and the statistical significance. So what we've shown is that these agents inhibit primary growth and metastasis in many different types of solid tumors. And importantly, both primary tumor growth, metastasis, and that there is synergy with at least some combination therapy. And that's something that is a focus for us now in trying to expand that. We've also found a wide therapeutic index. We haven't reached the maximum tolerated dose, and we found daily treatment for 60 days leads to no behavioral or organ toxicity in the mice. So our current plan is to go for glioblastoma as our first clinical development target. And these are surgical specimens, 2 different patients stained either for HIF2 alpha or HIF1 alpha. And so you can see that both can be expressed in glioblastoma. This is an orphan indication, and bevacizumab is approved for recurrent glioblastoma. This is Avastin, or anti-VEGF antibody. But it doesn't prolong survival, and tumor resistance is attributed in part to HIF activation. So the predicted therapeutic profile of 64B could make it the preferred treatment because it crosses the blood-brain barrier and inhibits the VEGF target, as does bevacizumab, but it also inhibits other processes, including invasion, adaptation, angiogenesis, and tumor cell survival. So our current status is we're working on pre-formulation and formulation studies. The majority of the work had been done in academia, where they weren't thinking on how to get compounds into patients. And so that's one of the things that we're working on, CMC process development. And an area where we're looking for collaboration is in efficacy studies in combinations with other agents in several different tumor models to tee us up for IND-enabling studies.
Thank you so much, Dr. Margaret, for your amazing presentation and showcasing your preclinical stage company.